ventricular fibrillation. He's shocked 10 times in the field, given amiodarone times 2, epinephrine times 1. He arrives to the hospital with mechanical CPR ongoing with a Lucas device. He has an additional 5 shots, so a total of 15 shots. He gets an additional 6 doses of epinephrine, so a total of 7 milligrams, and then gets a lidocaine infusion. He achieves return of spontaneous circulation after 57 minutes. His initial point of care VBG shows a pH of 7.1, a PVCO2 of 70, and a lactate of close to 8. His bedside echo shows an EF of 10 to 15% with no prior cardiac dysfunction. And on neurologic exam, he has a 4 score of 4. And so the 4 score, very similar to the Glasgow Coma Scale score, but we get 4 points for eye response, motor response, brainstem reflexes, and respiration pattern. And so this patient only has brainstem reflexes, no motor response, not breathing above the ventilator, not following any commands, of course. So who thinks this patient is going to have a good outcome? All right, so we got no hands up, right? So there are actually illness severity scores that we can use that can really help guide us in the acute setting, that can predict probability of poor neurologic outcome and probability of mortality. My favorite of the scores is the RCAS score. This was initially derived from a Japanese cohort. And the RCAS score is very intuitive because it thinks of the things that we automatically think of that define a low flow state. So the initial rhythm, whether it was shockable or non-shockable, whether the event was witnessed and how long of CPR was given, the pH on arrival, the lactate on arrival, and the GCS motor score. And you can see that there's a formula here where things are weighted differently. And so your motor score is weighted the most highly because it's the most predictive of outcomes. This score ranges from 0 to 18.5, with 0 to 6 being considered low severity, 6 to 14.5 being considered moderate severity, and then above 14.5 being considered high severity. And we'll go back to this a few times because I hope to convince you guys throughout this talk that the severity of post-cardiac arrest syndrome matters, and it's not just has or does not have hypoxic ischemic brain injury. So you can see here that at 30 days, this is derived from the Japanese cohort, although we did validate the score in our population, that the predicted probability for poor neurologic outcome is about 56%, and the probability of mortality is at 20%. So maybe a little bit lower, actually, than you were thinking just based on your gut. There's also other scores. So one that I have up here is the Miracle 2 score. Very similar factors that it brings in. This patient is also a medium risk by the Miracle 2 score. So this patient intermittently starts following commands on post-cardiac arrest day 10. His course is complicated by delirium, dysphagia. He does require a feeding tube, but does not require a tracheostomy. He's discharged to acute rehab after a month. He actually is able to have his PEG decannulated, and he has recovery of his ejection fraction to 43%, is asymptomatic from a cardiovascular standpoint, although he did have an AICD prior to discharge. And at 90 days has a modified Rankin scale score of 2. So he has some slight disability, but is independent in all activities of daily living. I highlight this case because good outcomes are possible. I can show you many cases that are similar to this case who have had a good outcome, a maybe unexpected good outcome. And the management that we provide in the ICU is critical to being able to provide this high quality outcome. So hypoxic ischemic brain injury, which is the brain injury that develops after cardiac arrest, is a global injury and is a result of both the primary injury that occurs while a patient is being resuscitated. For out-of-hospital cardiac arrest, we don't always have control over that, but for in-hospital cardiac arrest, you can give a whole talk on resuscitation techniques to minimize the primary brain injury. This talk is going to focus on secondary brain injury, which is what happens in the hours to days after return of spontaneous circulation. And we are focused on minimizing reperfusion injury, which could be worsened by hyperoxia, hypoxia, hypocapnia, hypercapnia, abnormal temperature dysregulation, and hypotension. And so we're going to focus today on temperature control, hemodynamics, and ventilator settings to minimize secondary brain injury. So we're going to start with temperature control. So it would not be wise of me to start without reviewing some of the old data on temperature control. And I'm sure that most of you are aware or have seen these publications. In the 2002 time period, the Haka and Bernard studies were published. This is looking at moderate hypothermia, so 33 degrees versus no cooling device. And this showed both survival and neurologic outcome benefit. Then fast forward to 2013, we have the TTM1 trial that's comparing moderate to mild hypothermia. So we're looking at 33 versus 36, and there's no difference in outcomes. I'm going to fast forward a second to TTM2, which is in 2021, which is the largest temperature control trial to date, and looked at 33 versus targeted normothermia, and again, showed no difference between moderate hypothermia and fever control. But I will get back to this point in a second, because I think a lot of what the talk about today is dissecting the clinical trials and the methods that are used to understand what this data is telling us. I'll also add here that the Hyperion study was published in 2019. This is the first study looking at a different group. This is the non-shockable group. And while it was a small difference, there was a neuroprotective benefit seen of moderate hypothermia in this group of predominantly out-of-hospital, some in-hospital cardiac arrest patients with non-shockable rhythm. So I think point one is that the studies that have been published to date are really not generalizable to the patient population that we see. So this is just a graphic showing some of the arrest-related details, patient demographic information to get at the illness severity and comparing the patients that we see at our institution, so 406 patients out of hospital cardiac arrest between 2014 and 2022, with what has been published in literature. So what you can see is that while our population is overall more similar to the Hyperion trial, which looked at non-shockable rhythm arrest, because overall our rate of shockable rhythm is 30%, we have even a sicker population than published in that trial. So our lactate, our average lactate is 9 compared to 5.8. And if you look at our overall rates of witness arrest and bystander CPR, which are huge predictors of the quality of resuscitation that they received, they're significantly lower than what's been published in the literature. Actually, New Haven has one of the lowest rates of bystander CPR across the country. And so we have to think about our population of patients differently. You can see that when you compare our institution to the TTM2 trial, the survival rate is less than half. The good neurologic outcome rate is less than half. And so this is not the same population, and we can't just take that clinical trial data and apply it to the population we're seeing. The other thing is that individualization matters. So there have been multiple studies looking at this over time, that the severity of post-cardiac arrest syndrome influences the benefit of different severities of temperature control. So if you look at the Okazaki paper in 2019, they looked at illness severity defined by a lactate level. So if your lactate was less than 12 following resuscitation, there was no difference between moderate and mild hypothermia. But if your lactate was over 12, you benefited from moderate hypothermia at 33. This has been replicated over and over again. So the same thing was found using a PCAC score, post-cardiac arrest category score, as a measure of illness severity. Same thing was found using the RCAS score as a measure of illness severity. So if you are in this moderate group between 6 and 14.5, you did better when cooled to 33 than if we used 36 or normothermia. And then the same thing has been shown using core temperature as a marker of illness severity. So we see patients who present cold. Those patients in general have a higher mortality rate than patients who present normothermic. That's likely a marker of the severity of their post-cardiac arrest syndrome. And it turns out through the Kim paper that if you warm those patients and treat them to 36, they do worse than if you keep them at their initial temperature of 33. And then lastly, in 2022, the Natuma group looked at EEG background. And so I'm not going to get into the extensive categorization of how they classified moderate encephalopathy on EEG. But if you had moderate encephalopathy on EEG, you also did better, had better neurologic outcome when cooled with moderate hypothermia. So I think it's really important when we think of temperature control that it is not as simple as it works or it doesn't work. Actually, for patients who are presenting with severe illness, with high illness severity, there's likely nothing that we can do that is going to improve their outcome. For patients with mild severity, actually, we run the risk of inappropriate withdrawal of life-sustaining therapy. So if we cool them to low temperatures and that requires sedation and paralysis, and they were going to wake up at 72 hours and now they don't, and we are overall nihilistic because the likelihood of good outcomes is low, you might expose someone incorrectly to withdrawal of life-sustaining therapy. And so I think that is why those two groups don't benefit. But this large group in the middle, which I will say is the vast majority of the patients that we treat at our institution, fall into this moderate group who are likely to benefit from hypothermic temperature control. The other challenge that we're facing is how do we look at this intervention? So temperature control is not one intervention, but it is studied as if it is. So the time to initiation, how quick we are to connect a device matters. How quick we are to actually lower the temperature, which is the induction time. What method we use. So most of these studies, you were allowed to use a range of devices from cooling blankets all the way up to intravascular cooling, but they probably have a different effect. The length of cooling. So this is what's being evaluated by the ICE-CAP trial. Is it better to cool to 6 hours or to 72 hours? Is there a dose response? The management of shivering and sedation, which I would argue is probably one of the most under-recognized and important factors, is that when we expose people to hypothermia and they don't have severe catastrophic brain injury, they are going to fight cooling. They are going to shiver and generate heat. And if we don't block that heat generation, we're not actually doing anything with our therapy. And then the rate of rewarming, right? Fast rates of rewarming have been linked to brain injury. And I don't think we've, as a group, been able to accomplish trials that have been focused on all of these variables. So when we talk about the quality of temperature control, it's also important that time to achieve target temperature has been really selected as a variable of interest, but it is an extremely flawed variable of interest. And the reason is because there's two separate things that are taken into account when we talk about time to target temperature. There's the pre-induction time, which I would argue we talk less about, the time that it takes us as providers to put on a device and start cooling the patient. And then there's the induction time, or the induction rate, how quickly they drop their temperature. But that can be related to patient-related factors. So they came in cold, they're not shivering, they quickly cool, but that's associated with poor outcome. Versus they came in warm and we treated them with sedation paralysis and early connected the device, and that's high quality. And we have no way to decipher between the two of those. So here's an example of two different patients. This is the Arctic Sun device for patient A and patient B. What you're looking at here, and what you should pay attention to on an Arctic Sun device, is the trend indicator, which is telling you what is going to happen to your patient in the next hour. The flow rates, which are telling you if the water is adequately moving through the device, because the way this device works is that it circulates cold water on the skin, and it's supposed to cover 40% of the body surface area. And so if you're not getting adequate flow rates, you're not actually moving that cold fluid, and you're going to inadequately lower body temperatures. And so patient A, this is a patient with poor quality cooling. The trend indicator is up 4 bars. Each of these is 0.5 degrees Celsius. This is telling you, despite the device being set to 33 degrees Celsius and this patient being at 35.2, this patient is going to warm by 2 degrees in the next hour. So this is what I call ineffective cooling. We put on the device, we stop paying attention to the details. Patient is generating heat. We think we're treating them, but we're not. Patient B, you have no idea if this is high quality cooling or if this is a patient with severe brain injury. So this patient is connected. They are rapidly dropping temperature. They're dropping temperature by 1.5 degrees in the next hour. And they either got sedation and paralysis and are effectively cooling through a high quality approach, or they actually have severe brain injury, didn't get any treatments, and are not resisting the device. And so we don't have a way to tell that. And so a lot of the trials that we're looking at have not been able to answer this question, and you will lose a signal if you don't know if your treatment is standardized. So just going back to preclinical data for a second, we know that delays to temperature control may negate the neuroprotective effects. So this is a study done in 2011. It is using an adult Long Evans rat model of asphyxial cardiac arrest. And what they did is, following resuscitation, they connected temperature control, or therapeutic hypothermia as it was called at that time, at 0 hours, 1 hour, 4 hours, 8 hours, and then did a normothermic model. And what you can see is, both for a survival function and then the neurologic function score, is that hypothermia, when connected rapidly, had a very significant neuroprotective benefit. But that neuroprotective benefit decreased over time and was completely negated at 8 hours. So once you connected it at 8 hours, it was no different than normothermia. We have not taken a good look at this from a patient standpoint, a clinical trial standpoint. And one of the reasons is that we don't collect data on time to initiation. We globally collect data on time to target temperature, and we already discussed why that's flawed. But if you overall look at the clinical trials that have been published, because each of them have different methods, mostly using local hospital policies for temperature control. What you can see is the first thing that I'd point out is that the mortality rates vary significantly. And we're talking between 28% and 52%, despite all of these clinical trials enrolling predominantly cardiac rhythm arrests with witnessed arrests. They're very similar inclusion criteria and have a huge range of mortality. The other thing I'll point out is that when we look at time to achieve target temperature, and that is on the y-axis on the right, the studies that overall had a shorter time to achieve target temperature had lower mortality. And if you look at the devices in the studies in green, which use intravascular cooling as the predominant cooling method, all of those studies had lower mortality rate. So we tried to look at this in our population of patients, and we're working on publishing this data. But what you can, so this is 350 patients that we looked at retrospectively, and we were able to reduce the pre-induction times after the initiation of ICE-CAP. So once we started enrolling ICE-CAP requires that you achieve target temperature within 4 hours of 911 call. We had to come up with policies and procedures to figure out how to do this, because if you actually look over the years, our average time to connect a device is 5.5 hours. We historically have waited until a patient got to an ICU to connect a cooling device. And so we started bringing devices down to the emergency department and rapidly deploying cooling. And so we were able then to have a subgroup of patients who had a short pre-induction time. For the purposes of this study, we defined short pre-induction time by less than 3 hours from hospital arrival, and prolonged or late was over 3 hours or over from hospital arrival. And because there are differences between groups, we did inverse probability treatment weighting, and I'll just point out that the weighted group is what we're predominantly looking at here. But you can see that those who got early initiation of temperature control, 28% of them had a good neurologic outcome versus 15.5 in the group that had late pre-induction. And when you look at this as a measure of time, this is very consistent with what we see in the animal data, and that if you have delayed initiation of temperature control, your log odds of good neurologic outcome decreases over time. And so I think one of the big challenges that we're facing on research in this area is that we don't know the therapeutic window, right? So if you go back to the 1990s when the early TPA studies were published, and there was initial concern that it was causing harm, it was causing intracerebral hemorrhage, and it wasn't causing benefit. Well, that was because we didn't identify the therapeutic window. We identified that the therapeutic window and that time is brain, and now we see that it's a very robust medication with significant patient benefit. And so I think we are just not there yet from a temperature control standpoint. The other challenge that we face is defining what is high quality temperature control. So we talked about how all of these factors influence each other and that they need to be standardized. There's only one publication looking or defining high quality temperature control, and that's from DeFazio and his group. The way that they define temperature control, though, is a little bit more focused on the ICU side and not on the temperature induction side. So they looked at time from arrest to target temperature, which we already talked about why that's flawed, overcooling, overshoot, temperature variability, rewarming rate, and the presence of fever despite temperature control. While their study was not, did not have the sample size to actually look at outcome, what they found is that only 16% of the TTH-48 study, which is a large clinical trial, had high quality temperature control. And so this just shows you that of the studies that are published, they are severely limited by standardization of the intervention. So our group is trying to develop a definition of high quality temperature control that really applies to induction, because if you don't start the device within the therapeutic window and you don't treat shivering thermogenesis, the other details probably don't matter. And while they may matter, if we don't tackle the first part, we don't get to the second part. And so the score that we developed is really focused on the time to initiate and then the use of adjunctive and non-adjunctive adjunctive pharmacologic and non-pharmacologic agents to treat shivering thermogenesis. So this is just some preliminary unpublished data, but you can see the quality score range between 2014 and 2022 in our institution. This score goes up to 7. We are at best achieving a 3. But you can see that with efforts to start device initiation in the emergency department and enroll in ICE-CAP, we've actually increased the quality of our cooling. This is an analysis that was done as a continuous analysis, adjusted for all factors that influence survival and good neurologic outcome. And you can see that the higher quality the increase in survival and good neurologic outcomes. So we are trying to look at this in a multi-center prospective way. We are working with the Siren Network, and we're currently trying to obtain funding for a study called Real World Accelerated Cooling in the Emergency Department for Cardiac Arrest Patients, or RACECAP. And the purpose of this study is to investigate the relationship between high quality cooling and survival with functional outcomes, and then to also implement an emergency department initiated, not an ICU initiated, temperature control protocol that's standardized, that focuses on early implementation of cooling and adjunctive treatments to treat shivering thermogenesis. Unfortunately, it would not be ethical to randomize people to high or low quality cooling. And so the way that we plan to do this is by using a step wedge design where we have 4 sites that have variability in practice. We have done survey studies, and there is significant variability, as you can imagine, in temperature control protocols and how people practice. And so by understanding site-related variability and then implementing a protocol to standardize cooling, we will be able to see a wider range of quality and pre-induction times across this x-axis here, and then be able to hopefully identify not only what is the therapeutic window of temperature control, but what are the optimal parameters? Do I need to achieve it by 3 hours, or it doesn't matter? Do I need to achieve it by, do I have 6 hours? Is earlier always better, or is there a point at which it doesn't become effective at all? All right, so moving on to hemodynamics. So we know that blood pressure matters. We've had an inability to show that within our clinical trials in cardiac arrest. So we know that cerebral perfusion pressure is your mean arterial pressure minus your intracranial pressure. And then after acute brain injury, the intracranial pressure is relatively increased, and for some, maybe significantly increased. But if there is even a relative rise in your intracranial pressure, that means that you need a higher mean arterial pressure to maintain the same cerebral perfusion pressure. Part of the challenge is that we know that physiologically it makes sense that we would need a higher mean arterial pressure after cardiac arrest, but there have also been flaws in the design of the blood pressure trials. So I'm going to get into those flaws in a second, but just conceptually, we know that hypotension occurs in the vast majority of our patients post-cardiac arrest. I think at last check, we were about 65% of our patients were requiring vasopressors. And it's associated with worse outcomes. There are multiple studies that look at autoregulatory failure, which is the failure to maintain cerebral blood flow despite wide ranges of mean arterial pressure. And that occurs anywhere from 1/3 to 2/3 of patients following cardiac arrest. And one of the reasons that I think we have not been able to show that blood pressure matters in these prospective trials is that mean arterial pressure likely is not reflective of what's actually happening in the brain. So this is a figure from the Box trial recently published, looking at low blood pressure versus high blood pressure. They were randomized to either low or high blood pressure. The first thing that I'll point out is that while there was overall separation between the groups, you can see that there's huge overlap in the blood pressure. They also studied the first 48 hours, and they did not look at anything beyond 48 hours, but I would argue that maybe 48 hours is not the correct time period. If you think about pathophysiologically why we think higher blood pressure matters, well, your ICP is increasing over time and actually probably peaking 2 to 3 to 4 days. So not in that first 48 hours where you might be somewhat protected. And then we'll talk again about why population-based targets might not be appropriate, and we need to take a more individualized approach. So looking at these 2 examples, you have patient 1 in yellow and patient 2 in red. These 2 patients both have a mean arterial pressure of 75 for an hour period. But patient 2 has a blood pressure of 90, their blood pressure crashes, goes to 50, the pressors are titrated, and then they overshoot, and their mean for that 1 hour is still 75. So are these the same patient? And we all know the answer is no, right? Patient 2 is exposed to cerebral hypoperfusion, and we are not currently quantifying that in our trials. So we took a look at this. And what we did is, instead of looking at mean map, which actually showed no statistical difference in our cohort, we looked at the proportion of time with the mean arterial pressure below a certain threshold. So the threshold that we selected was 80. And then we also looked at time. So is there a different response depending on time? So what you see here is in the blue line that for the first 24 hours, actually there is no correlation between the proportion of time below a certain MAP goal and probability of good neurologic outcome. But there is a strong correlation between 25 and 96 hours, suggesting that this is dynamic and changes over time. And that the more time after 25 hours, so after day one, the more time you spend with a mean arterial pressure below 80, the less likely you are of having a good neurologic outcome. So moving into how we look at this for an individual. So I just need to step back for a second and explain cerebral pressure autoregulation so that we can focus a little bit on how we can look at individual needs. So cerebral pressure autoregulation, we discussed, is the ability to maintain cerebral blood flow as a constant despite wide ranges of pressures. So what you can see here is this yellow line is a healthy individual, and anywhere between a MAP, somewhere around 50 and 150, their cerebral blood flow is constant at about 50. But if their blood pressure falls below 50, they are maximally vasodilated cerebrally. They can no longer let more blood flow in. Their total cerebral blood flow will decrease, and this is why people become unconscious. They syncopize when their blood pressure is low. On the alternative side, if your blood pressure becomes really high, you have MAPs of 180 and 200, you are maximally vasoconstricted. You can no longer vasoconstrict more than that. You are going to have cerebral hyperemia, and you can drive cerebral edema or intracerebral hemorrhage. And we know that patients with acute brain injury, including the cardiac arrest population, have disturbed autoregulation. And so they are now this red line. So they have a much more narrow, typically in cardiac arrest, right shifted, but they can be left or right shifted, curve where the area where you are protected is very small. And so you are at increasing risk for cerebral ischemia or hyperemia and edema. And we won't know that number without monitoring, right? Hard to predict. So our goal is to find that flat part of the curve to minimize the chance of developing cerebral ischemia or cerebral edema in that patient. And we can do this non-invasively using something called the tissue oxygenation index or the cerebral oxygenation index. Both terms will be used here. Sorry for the interchange. But we're looking at the change in the cerebral blood flow over the change in mean arterial pressure, right? And if we want to be on that flat part of the curve, you don't want a change in your cerebral blood flow. So you want that to be close to zero. And so using near-infrared spectroscopy, we could use regional cerebral oxygen saturation as a proxy of your cerebral blood flow and look at the change in regional cerebral oxygen saturation over a change in mean arterial pressure, which we get continuously from an arterial line. We can track these changes dynamically over time and get real-time correlation coefficients. And this is what this looks like when we are deploying one of our devices. So we have a laptop that has a computer program called ICM Plus that integrates all of this data and is giving you data that you can interpret. You have stickers on the forehead, which are pulling regional cerebral oxygen saturation as a proxy of time. And you can see that you get this cerebral oxygenation index or tissue oxygenation index as a factor of time. That could then be plotted on the y-axis across a whole host of mean arterial blood pressures that you see, and allows us to then outline the limits of autoregulation for that individual. So because we want to be below zero, or it turns out that that number is between 0.2 and 0.3, we can then outline where the patient crosses that line and what blood pressures they're seeing are on the flat part of the curve. And so for this individual example that I'm showing you, that is between 60 and 74. But it allows us to dynamically track these values over time as things change by days or by other situations that are happening, as your cerebral autoregulation also is going to be influenced by your carbon dioxide and other things that are affecting your patient. All right, so just to give a short summary of patients that we've monitored. So this is just a summary of 39 patients that have been monitored in the medical ICU. And what I want to point out here is this is a relatively sick population of patients. So 30% of the patients monitored had overdose etiology arrest. They have an average RCAS score of 10. So this is a high illness severity group. And while none of this was statistically significant, what I want to point out is that the tissue oxygenation index in those who survived was lower than those who died. And this lack of signal here from a statistical standpoint is likely a sample size issue. I also want to point out that overall, that the percentage of time outside of the limits of autoregulation was quite low. And I would say that's because we do a very good job of maintaining the perfusion that they need. But again, you can see that those who survived had a lower time outside of the limits of autoregulation than those who died. And so just to plot out what this looks like, when you look at the limits of autoregulation, first, it does change over time. So consistent with other data that we've seen, the value is lowest on day 1 and increases over time, which pathophysiologically makes sense. But I would also point out that 94% of our patients had a lower limit of autoregulation above 75. And so when we talk about population-based thresholds and targeting 65, of which the newest critical care guidelines for cardiac arrest actually recommend 80, unless you have an ability to do individual limits of autoregulation, that those population-based thresholds are likely underdoing it for the vast majority of our patients. I will also point out that our data is somewhat limited in that you can see in blue the optimal map for the patients and the red, the map that they achieved. We did really well in achieving close to optimal targets. And you can see that here in the graphic below, there's most patients spent less than 25% of their time outside their limits of autoregulation. And that does impact our ability to look at if this is beneficial from a mortality and good neurologic outcome standpoint. But I think either way, the descriptive data is really important because it's consistent with what we already know, that the limits that individuals need are dynamic and likely higher than population-based thresholds. So just to move into other work that's been done in this area, Maipender Sikhen and his group at Vancouver do invasive neuromonitoring for cardiac arrest patients, where they put in an ICP monitor and then other markers to look at cerebral oxygenation from an invasive standpoint. And they did a retrospective analysis looking at those who had an invasive monitor versus those who had standard of care. This is a small cohort, so 21 patients who got goal-directed care and a matched standard of care cohort of 21 patients. What I'd like to point out is that those who had an invasive monitor and had goal-directed care on average had significantly higher mean arterial pressures. They tended to be cooled for longer durations because they did not rewarm people if they were in physiologic distress and kept them colder for longer periods of time. And what you can see is that the likelihood of a good neurologic outcome was 29% in the group that received goal-directed care and 0% in the standard of care. Now, this is hypothesis generating, very small sample sizes, but it really does suggest, along with all of the other data that we have, that there are profiles of secondary brain injury that we can not only detect, but that actually, if we intervene, that we could potentially prevent. So I don't expect you all to be able to read this, and I can send out documents and slides later, but just to highlight that we do have an invasive neuromonitoring protocol at Yale. The patients who are excluded are those who are unlikely to benefit. So, right, if you have catastrophic brain injury on your initial scan, it is unlikely that an invasive monitor and adjustment of physiologic properties is going to lead to an improved outcome. But also patients who need anticoagulation or they need to be proned, right? Those are not patients that we're putting in an invasive neuromonitoring on, but just to make sure that you guys are aware. So if you do identify patients who you think would benefit, that you do reach out to us. I just wanted to give you an example of good outcome and poor outcome from patients that we have monitored. This is an example of a patient who ended up having a good outcome. And what I'm going to highlight here is that when we have an invasive monitor and we use intracranial pressure as our proxy of cerebral blood flow, we then refer to that index as the pressure reactivity index. But it is the same thing conceptually as the cerebral oxygenation index or the tissue oxygenation index. What you see on this top, which is green and red bars, is the pressure reactivity index. So green is good, yellow is intermediate, red is bad. Then you see, similar to what I showed you before, this chart that's outlining the limits of autoregulation. And then you see a histogram with a density plot of where this patient is in that. And so we always want where the patient is from a blood pressure or cerebral perfusion standpoint to line up with the lowest part of the graph, because that means that we're achieving optimal. And so this patient overall does pretty well from that standpoint. And what you can see is that there are definitely periods of dysregulation, but we're able to get the patient back in the green with different maneuvers. And this patient was treated with both hyperosmolar therapy, 23.4%, and blood pressure augmentation. And what you can see in this histogram below, which I don't expect you to be able to read, red is bad, yellow is good, is that overall, for the recording duration, which was 6 days, this patient spent about 28% of her time dysregulated. Now, if you go to a patient with a poor outcome, we don't actually have limits of autoregulation. Every value that we're seeing is in the dysregulated zone. Majority of this recording is red. This patient is not falling where they need to be. And actually over 82% of the time is spent dysregulated. And so we are still learning about invasive neuromonitoring and what we can gain from this, but it's likely beneficial not only for identifying markers of ongoing secondary brain injury of which we might be able to intervene, but also prognostically. All right, so in terms of what else we can learn from the multimodal monitoring data, so when we do multimodal monitoring, we also put in probes to look at brain tissue oxygen tension or cerebral blood flow, and lactate pyruvate ratio, which is microdialysis. And the goal of that is to look for active signs of ischemia. So what I have highlighted in this box is when the brain tissue oxygen tension, which is this pink box here, falls below 20, that's concerning for cerebral hypoxia. And when the lactate pyruvate ratio goes above 40, and that's that purple box there, that's concerning for ongoing active ischemia or risk for secondary brain injury. And I highlight here also the brain temperature to show you that this arrow is when rewarming occurs. This has been shown over and over in other published data that rewarming is a relative period of risk for these patients. And that they, as you see in this particular patient, the lactate pyruvate ratio starts to climb as you start to rewarm. This is another graphic. Again, I don't expect you to be able to read. It's very small print, but this is the brain temperature on the x-axis versus the intracranial pressure on the y-axis. And what you can see is that as the brain temperature rises, the intracranial pressure rises. And so rewarming is a period of relative risk for these patients. All right, moving on to ventilator settings. So it has been published over and over again. There's a U-shaped curve for PaO2 and PaCO2 in both survival and good neurologic outcomes for cardiac arrest patients. And optimal PaO2 somewhere around 100 to 200, with hypoxia and hyperoxia both being considered harmful. And then same thing for PaCO2. On average, for most patients, 35 to 45 is the sweet spot, with higher risk of mortality when you are hypocapnic or severely hypercapnic. But this also is going to have an individual pattern. And if you already have cerebral edema or are at risk for cerebral edema or are out of your autoregulatory window, these things can interact with each other in a way that you might not predict the response. And so for these two individual patients, I'm showing you a graphic that we can generate on this computerized program, ICM+, where I can plot on the y-axis intracranial pressure, and on the x-axis, I can graph end-tidal CO2 as a continuous variable. And what you see is for this particular patient, the higher the end-tidal CO2, the higher the ICP. And this allows us to adjust the ventilator settings actually to put this patient in a zone where their end-tidal CO2 is not driving a rise in their intracranial pressure. And then for this patient on the bottom, they had a perfusion monitor. So we're actually looking at brain perfusion. And what you see is similar signal that as end-tidal CO2 rises, you have increased brain perfusion. But also as end-tidal CO2 drops, you have decreased brain perfusion. And what you can see is that when we're getting into the 20s here, we are below normal brain perfusion. And so we know from our invasive monitoring that hypocapnia is going to drive secondary brain injury by causing a state of brain ischemia, right? Because you're causing cerebral vasoconstriction and you're letting less blood flow in. And so there's a fine balance between not driving raised intracranial pressure and perfusing the brain to where it needs to be perfused. And this is why we're very specific with the goals that we recommend, but they might actually, and likely do, vary based on the individual and what other factors are going on with them. All right, jumping into just areas of continued work. So we talked a lot today about methodological limitations and how that impacts what we know to be helpful or non-helpful therapies in cardiac arrest. Well, one of the biggest barriers I would say that we're facing is that patient selection is a real problem. We don't have any early biomarkers to predict patients who are unlikely to benefit, other than these illness severity scores, which are not perfect by any means. And if we enroll patients into a clinical trial that have a 0 chance of neurologic benefit, of course, we're not going to see a signal. So this is work that we did in developing a score called the brain death risk score. And the reason that we focus on identifying those likely to progress to brain death is multifactorial. One, it has huge implications from a resource utilization standpoint, and then what you actually recommend, right? Cooling unlikely to be beneficial. And actually, if we cool these patients to 33, we might delay the diagnosis of brain death. And so from a clinical standpoint, it's really important to know who's likely to progress to brain death. But it also, other risk scores are at high risk of being used inappropriately because of withdrawal of life-sustaining therapy, right? So if 65% of my patients have withdrawal of life-sustaining therapy, and I'm generating a score, and their cause of death is withdrawal of life-sustaining therapy, I don't know if they actually died because of inappropriate withdrawal of life-sustaining therapy or because they were going to have a poor outcome. But when I predict brain death, that is a medical legal diagnosis. It happened independent of other things. And I can be a little bit more reassured that this is a true risk score. So what we did is we pulled together variables that predicted development of brain death. And those variables include your initial rhythm, right? Non-shockable rhythm are more likely to progress to brain death. It includes etiology. Drug overdose arrests are way more likely to progress to brain death. It includes signs of ischemia on your early head CT within 24 hours, although I would say the vast majority of patients enrolled in this cohort had a head CT within 6 hours. Your full outline of unresponsiveness score, which again is very similar to your Glasgow Coma Scale score, and a 4 score of 0 means brainstem areflexia. And then age, because younger patients have full brains and are more likely to progress to brain death. And if it turns out that the threshold point here is 5, if you have a score of 5 or above, this is very predictive in both the development and validation cohort for brain death, with an AUC of 0.93 in the development cohort and 0.85 in the validation cohort. And more importantly, because we want to make sure that we're not using this inappropriately, there were 0 patients with a score of 5 or above who survived or had a good outcome. And so that makes me feel better that it's not running the risk of preventing therapies to patients who otherwise might have had a chance. And so I think this is something that we need to look at a little bit more in terms of patient selection for clinical trials, but also for interventions acutely, and then acute conversations with New England Donor Services and making sure that we're prioritizing the correct aspect of care. Other areas of continued work, we are very limited in our prognostication. So actually a small percentage of our patients go on to have MRI, and that's largely because across the United States and worldwide, MRI is not easily accessible. It is challenging to transport these patients out of the ICU. And we really don't know what the optimal time frame is for looking at MRI findings and predicting outcomes, because the data is limited by few MRI findings early in the course. There is some early data that suggests if you have an MRI within the first 6 hours and you already have ischemic changes on that, that's pretty highly predictive for poor outcome. But it is not feasible, as we all know, to get a patient to MRI within the first 6 hours, and that probably wouldn't be the right thing to prioritize for patient care. And so portable MRI has the ability to scan someone at the bedside. We were able to do this easily in the emergency department and also in the ICU to evaluate the degree of brain injury, but it also has the added benefit of now I can look longitudinally over time how the injury develops, and that is going to be very helpful for understanding the mechanisms of secondary brain injury and serving as a radiologic biomarker. In this figure here, you can see the portable MRI and then the conventional MRI. And you can hopefully see with the red arrows, the diffusion weighted imaging. You can see that there is hyperintensity in the caudate, in the putamen, cortically, very similar to what you see on a conventional MRI. And you can see that same thing on a FLAIR. And so this was a scan that was done at 49 hours, but you can clearly see that these findings of severe hypoxic brain injury are visible on portable MRI. This is another example of a patient who had portable MRI who had an early CAT scan showing some gray-white differentiation loss, some sulcal effacement. They had a MRI done at portable MRI done at 4 hours, and then a repeat portable MRI done at 49 hours. And you can see that there's evolution over time. So hypoxic ischemic brain injury is not like acute ischemic stroke. We do not see all the findings up front. In fact, you can be fooled if you don't repeat these imaging in delayed fashion. And I think portable MRI is an avenue to understand these changes longitudinally in a way that we can't do with conventional MRI. There's a lot of people in this group who are actively working on innovation from a documentation standpoint. So we are lucky to have an innovation award to look at how we are documenting cardiac arrest, how they integrate with the EMR. So as you all know, we are years behind in terms of documentation for cardiac arrest. It's one of the only things we document on paper. The team who's receiving a patient rarely knows any of the arrest-related details when they're receiving that patient. And so there's a tremendous opportunity to standardize this process, to actually use this process to give you triggers for following guideline resuscitation, but then also for it to integrate into the electronic medical record. And so we have a really great group here that's working with Epic on developing a mobile resuscitation solution. And then we also know that improving care for the in-hospital side is not enough, and we need to also improve access in the out-of-hospital side. So we have, I'm really proud of the work that we've done on the in-hospital side. We're seeing significant improvements in neurologic outcome, but as most of you know, these patients are discharged. They often don't follow up with a neurologist. They often don't follow up with a cardiologist. They often don't see a post-ICU clinic, and they're seeing their primary care doctor who has a limited understanding of what happened to them and how to improve their rehabilitation, but also how to prevent this from happening again. And so we are lucky that we've been able to get help from two fantastic stroke nurse navigators who we started a pilot in February of this year. They are actively reviewing all cardiac arrest patients that are seen by the neuro ICU, which should be the vast majority of patients with cardiac arrest. To date, we have screened patients. 49% of the patients that we've screened have been enrolled. And I want to highlight that number because that means that in the past 2.5 months, 49% of people with a cardiac arrest at this institution has recovered to follow commands. That is a really high number and shows all of the hard work and dedication that people have been putting in to improve outcomes. Of the 18 patients that we've evaluated in this time period, they've all been placed for a cognitive evaluation. So not just a normal speech evaluation, but a speech language cognitive evaluation that looks for areas of deficit from a memory and functional standpoint. 14 out of the 18, despite following commands and having no clinical concern from the team that there was a cognitive deficit, were found to have significant cognitive impairment. And 12 of them have been referred to neuropsychology. You can see just some statistics here. So this is pretty much half and half so far in hospital and out of hospital cardiac arrest. We're currently tracking many patients' recovery. One of the things that I am very proud of is that you can see that the vast majority of these patients are either going home with services or without service or to acute rehab. And one of the goals of this pilot is to identify patients who have needs and actually be able to push while they're still inpatient for them to get acute rehab services and not short-term rehab. And then to make sure that they both follow up with neurology. I'm working with Denise in the post-ICU clinic to also make sure that they get access to the post-ICU clinic. And then make sure that if they have seizures or anything out of the ordinary on discharge, that they also follow up with our post-acute seizure clinic. And I want to leave time for questions. This work cannot be done without an amazing team. If I have left anyone off of here, I apologize. I tried to get as many pictures as I can, but there are so many invested people within this institution focused on the care of cardiac arrest patients and improving both in-hospital outcomes and access to care as an outpatient. So I want to deeply thank everyone for all of their devotion to this patient population, of whom is very close to my heart. Now let's have a questions.
Thanks for a fantastic talk. Do we have any questions in the audience? Yeah.
Thank you. Thanks, Rachel. I was just curious, your current state of care of post-arrest patients in the neuro ICU. Are you using your brain death score to exclude patients? Are you also integrating some of these precision approaches to hemodynamic monitoring? Because we are not in the MICU right now. And do you envision changing the protocols along those lines in the future?
Yeah, really good questions. So we are using the brain death risk score, at least from a purpose of decisions about temperature control, but we don't, we do also, part of that brain death risk score is the head CT. And so we are very cautious about making sure that we are not being overtly nihilistic, and that we are making sure that if we are not offering temperature control, or our focus of care is really towards organ resuscitation and clear communication and coordination with New England Donor Services, that there's a significant reason to do so. So we are using that score for that purpose. We are also using that score for candidacy for invasive neuromonitoring. In terms of, we've only had to date 9 patients who have had invasive neuromonitoring in the neuro ICU, and we are using physiologic parameters. So we have used hyperosmolar therapy, MAP augmentation, and other tools, adjustment of their carbon dioxide to see what is optimal. But we're still gathering data on that approach. I would say that the most recent American Heart Association guidelines that were published, the critical care guidelines, do recommend that if you have the ability to do this, that you should. And that MAP targets for patients who don't have the ability to have individualized goals should be closer to 80. In terms of our recommendations, we have not shifted towards requiring or recommending 80 for everyone, because it's not clear which population is most likely to benefit. But we are trying as a consultant team to be very thoughtful and recognize those that are maybe at higher risk of raised intracranial pressure, recommend higher targets. And we are in communication not only with leaders in your unit, but in the cardiothoracic ICU and others about the opportunity to potentially move and develop neuromonitoring, non-invasive neuromonitoring across the institution. It's just, that's going to take time logistically to be able to provide clinically. Yeah.
So Rachel, thank you for a fantastic talk. The part of your discussion where you were talking about the time to achieving target temperature remind me a little bit of past discussions on door to balloon time and things like that. And as I understood it, the real obstacle was processes. What are you discovering in terms of the obstacles to achieving target temperatures in a reasonable amount of time?
Really, really good question. There are a lot of obstacles. I think, so we actually surveyed all of the ICECAP sites to ask about these obstacles. And the number one obstacle was what we would term clinical skepticism, the belief that time doesn't matter. And so I think one of the barriers is, right, breaking down the research and making people understand that it is not yet a yes, no, and that there are a lot of variables, because if people don't believe the therapy works, then they're not going to prioritize it. So I think that's honestly the number one. The number two is that we have not done the greatest job in cardiac arrest of focusing on the implementation of interventions. And I think we are somewhat disjointed, because these patients can be in the hospital, they can be in the ED, and there's a lot of priorities happening at the same time, and a lot of different teams running different priorities. And so part of what RaceCap is planning to do is to actually standardize this protocol based on things that we've learned, which include you need to connect a device quickly, but you also have to understand the device you're using. So the biggest challenge that we have with surface cooling, and if you look head-to-head studies, there's not a tremendous amount of data that says surface cooling is inferior to intravascular cooling, but it's in the way that it's used. So I can't tell you how many times I go down and look at the device, and it is showing the patient's warming, or the pads are incorrectly placed, and the patient's sitting on the fluid delivery line, and so the flow rates are low. Or the wrong size pads were used, and so we're not actually covering 40% of the body surface area. So I think despite using this therapy for over a decade, there are significant knowledge gaps in how to use it effectively. There's also challenges with deploying new interventions. So we started deploying sedation and paralysis in the emergency department, and that took a lot of discussions with pharmacy and developing a protocol, and we are at a better place now, and I think that's why we're starting to see an improvement in the quality. But those things need to happen, and I think there's a lack of understanding of why those things are important. And so anyway, RaceCap, what it does is it designs a emergency department protocol. So if you look across the country, most places do not have an emergency department protocol. They're all ICU protocols, but boarding times are increasing. And so it is focused on the emergency department. It is focused on using intravascular cooling within 2 hours of arrival with the use of a sedation and paralytic pathway that's very outlined to be able to get all those things in quickly. And so I think there's multiple things, but I think that there are ways to answer this question. My biggest worry is that if we don't convince people that the problem's there, then it's hard to fix.
Question online. So how do you determine when to rewarm patients? Is it feasible to access all patients with cardiac arrest, such as the PERT protocol attempts to apply, like both inpatients and outpatients?
So the first question is about how do we choose to rewarm? So our standard hospital protocol is at 24 hours after initiation of cooling, we rewarm, and we rewarm at a rate of 0.25 degrees Celsius per hour. There is a subpopulation of patients that we will recommend slower duration of rewarming, typically about 0.125 degrees Celsius. And when we recommend that, the reason of recommending that is because I hear a lot of times that people are worried about hemodynamics and they don't want to cool a patient because of hemodynamics. Actually, cooling someone usually has a vasoconstrictive effect and their blood pressure is artificially elevated. Rewarming is a period of significant hemodynamic instability. And so if you rapidly rewarm someone, they will become unstable. And so the patients that we're typically recommending a slower rewarming rate are patients who are hemodynamically unstable, who might decompensate if you rewarm them too quickly. From a standpoint of research, the ICE-CAP trial is looking at variable durations. So it is separating the shockable rhythm arrest and the non-shockable rhythm arrest to see if there's a different effect in those two populations. And they're looking at anywhere from 6 hours all the way up to 72 hours. And so they're trying to see if there is a dose response curve and if it's different for different populations. I think more to come. I would say that there are limitations of that study, just as what we talked about with others. And so we'll have to interpret that with the context of what the data shows.
Awesome.
And
So
there was a second question, but
you have
okay.
you have most of it. So we're at 4 o'clock. If anybody's any other questions, they can, I'm sure, come down and ask Dr. Beekman. Thank you so much for joining us
Of course.
today.